I will not be talking about the hip. We're going to talk about wide-awake hand surgery, which is a technique to do minor hand surgical procedures with just local anesthesia with the aim of increasing patient convenience, surgeon convenience, and decreasing costs. And if you dive into this topic at all, you're bound to come across this acronym called WALANT, which stands for Wide Awake Local Anesthesia with Adrenaline and No Tourniquet. And those are the features of this technique, and we'll kind of talk about all of those as we go. So from a historical perspective, we all know that surgery is typically done in a hospital with general anesthesia, making the patient unconscious as a way of controlling pain and performing the surgery expeditiously. This dates back to the mid-1800s with the use of ether. Multiple other medications have been tried, including barbiturates and more recently propofol, which we still use for sedation. Other advancements to help patients breathe and perform longer surgeries are breathing apparatuses such as the ET tube or the LMA airway. And historically, even in hand surgery, we've used general anesthesia. But as more surgery has been done, more complications have been seen. As a central nervous system depressant and making a patient unconscious and breathing for them, the complications are not necessarily benign, whether they're derangements of the cardiovascular or respiratory system, problems with manipulation of the airway, or even the post-operative hangover from anesthesia, nausea, vomiting, grogginess. In hand surgery or peripheral extremity surgery, and even Dr. Oliver touched on regional anesthesia, which is a way to numb peripheral nerves with a local anesthetic, creating anesthesia to perform the surgery. Often this is combined with a general anesthesia or a sedation for patients. But this is especially suited for hand and upper extremity patients, as in the bulk of our practice for the past couple decades. With less general anesthesia and the addition of a regional anesthesia, the recovery time shortens. You can have improved post-operative pain control. That regional anesthesia can last for multiple hours after your surgery, leading to lower opiate consumption and less incidence of nausea and vomiting and grogginess. And this is sort of a schematic of how we perform regional anesthesia in the upper extremity, or the anesthesiologists perform regional anesthesia. There's multiple locations that you can bathe these peripheral nerves with anesthetic as they exit the spinal cord, whether that's as they exit in the neck, above or below the collarbone, or even in the axilla. Local anesthesia also dates back to the 1800s, where cocaine was originally injected into peripheral nerves for minor surgical procedures. Epinephrine was added as a way of decreasing the metabolism of the anesthetic and increasing the length of its function. It also acts as a, quote-unquote chemical tourniquet, as it's a potent vasoconstrictor and can limit bleeding. These are some of the common anesthetics that you may have heard of. They have varying durations of action. Procaine or Novocaine, which you may be familiar with from the dentist, is a short-acting anesthetic. Lidocaine, which we commonly use, is a medium-acting anesthetic, and Marcaine or bupivacaine is a longer-acting anesthetic. And we often combine these so we get a quick onset of action with the added benefit of a prolonged duration of action. So anesthesia for modern hand surgery, we use a combination of sedation, not necessarily general anesthesia, but monitored anesthesia care, which is generally done with propofol, but the patient maintains the ability for spontaneous breathing. It also provides an amnesic effect and some amount of analgesia. So this is combined with some type of block, whether it's in the neck or collarbone, or as we'll talk about a little more, as far as local anesthesia, more distally in the fingers or the wrist. And with effective anesthesia of the extremity from a local anesthetic, depending on where it's deposited, a couple questions arise, which has led to this sort of movement of wide awake hand surgery. And then the obvious one is general anesthesia or sedation even necessary for some of these procedures? We have effective pain control with our local anesthetic, so what benefit does a general anesthetic give us? And that may be important in some cases for an amnesic effect or an anxiolytic effect for patients in the general patient experience. Fear of being in the operating room and being awake as you're being operated on is something that would be very common. And the other topic that I'll talk about, particularly in relation to this subject, is the tourniquet pain. So the tourniquet is a mechanical tourniquet in most cases that's generally placed on the upper arm, which in a regional anesthetic is numb. But if your upper arm is not numb, the tourniquet, which is essentially a blood pressure cuff that goes up for the duration of your procedure, it causes a significant amount of pain over time. So the answer is sedation or general anesthesia necessary? It depends. Sometimes it is, yeah. And the other question is, if we're going to pursue this path, are there advantages to having a patient awake during surgery? And the answer to that is, I'll argue yes. Patients can participate in their surgery, which for various hand surgeries is beneficial, including tendon or fracture surgery, allowing the patient to move their hand on command, and you can see in real time the effect of your flexor tendon repair or your fracture fixation. The other benefits would be avoiding the risks of general anesthesia, so you don't have that grogginess. We'll talk about some more of the benefits of avoiding a general anesthesia in a few slides. And this is expanded, and this is even an ongoing movement. If all this is true, does surgery need to be done in a hospital? Does it need to be done in an operating room? And what impact does this have on efficiency and overall cost of care? But there are some hurdles, which we talked about, which is the tourniquet. So the tourniquet pain on the upper arm is something that we have to overcome if we're going to only anesthetize hands more distally around the fingers or the wrist. And we do this with the use of epinephrine. However, this has been a controversial topic, as many of you may have heard in your training, that there's a long-held dogma that you can't use epinephrine in the fingers because it's a potent vasoconstrictor, and these small blood vessels around the fingers, the vasoconstriction will be too much and you'll kill a finger and it will turn black and fall off. And this came from case reports, in the early 20th century, where this did happen. But as people looked into this more, and actually read these case reports and studied them over the past, couple of decades, they found that, it was Procaine at the time that was being injected as a local anesthetic. And they found that as Procaine sits on your shelf, it becomes more acidic. And there was even a report from the FDA that found that Procaine had a pH of about 1 prior to injection in some of these cases, which is extremely acidic. So when they compared the fingers that had this issue with Procaine, with and without epinephrine, they actually found that more fingers had a problem with Procaine alone than with epinephrine. So epinephrine kind of got the was kind of thrown under the bus for a long time. There's a surgeon, Don Lalonde from Canada, who has really pioneered this movement, and he has looked at a lot of different topics, but the epinephrine in the fingers is one of them. So they did a multi-center study with thousands of cases in Canada and really had no problems using epinephrine in the fingers. They had no cases of tissue loss, and they had no cases of even a need for a rescue with an antidote. This has been replicated in the United States with 4,000 cases with no anaphylaxis, no readmissions, no phentolamine reversal or tissue necrosis, and there's multiple other studies and thousands of other anecdotal studies of there really being no issue with epinephrine in the fingers. So that's really not an issue in our world anymore, and we use epinephrine safely in the fingers every day. And this eliminates the need for an upper extremity tourniquet. The potent vasoconstriction, as you can kind of see in a carpal tunnel incision planned here on the right side, that's the area where the epinephrine was injected. So for the duration of the procedure, which is usually quite quick, you really do have effective bleeding control. So what other benefits are there for the patient and surgeon with wide-awake hand surgery? For patients, that you don't need to be NPO or have nothing by mouth. So you can kind of ignore the don't eat or drink after midnight, which is especially important for certain patient populations such as diabetics. You really have no or a very short post-operative recovery period, which a long recovery period is usually related to the general anesthetic or the sedation that you get. So you have no nausea or vomiting, and you can drive to and from surgery. For the surgeon, like we mentioned about tendon surgery, patient participation in certain surgeries can be very useful. They can discuss with the circulating nurse or the surgeon in real time about what the surgeon is seeing, what their postoperative instructions are, and because you're doing the same surgery just with a different consciousness level of the patient, the outcomes are essentially the same. And then the next question, that is still being explored is what's the impact on, the economics of a surgical cost of care. So as you all know from, the news and media, the healthcare landscape is transforming. There's a transition from volume-based care to a value-based care, which is on the top of the minds of politicians, governments, and, health insurance carriers. And when you break it down, value is really quality over cost. So if we can maintain patient outcomes, patient experiences, or improve patient experiences while decreasing costs, we can really increase value, which has led to a shift in certain surgeries such as hand surgery to an outpatient setting in either an ASC or even office-based clinic settings. And this has been sort of looked at for carpal tunnel surgery and a variety of other surgeries. We'll just provide this one study as an example, which was done looking at open carpal tunnels with and without sedation done in a surgery center. And you can see that the operator, the in time of the time that you're in the operating room is essentially the same. The surgical time is essentially the same for a carpal tunnel release, 9.5 or 10 minutes. But the recovery room time is drastically different. So this has really pushed a lot of these surgeries into a more minor setting. For your 10-minute carpal tunnel release, you really need to spend 90 minutes in the recovery room versus 7 minutes, which is essentially the time it takes you to tie your shoes and put your coat on. And this, translates into dollars too. So, you can see the cost difference they found even in an operating setting of thousands of dollars per carpal tunnel, multiplied by the hundreds of thousands of carpal tunnels that are done every year, across the country, and you can see a huge cost relief from the system. So, even in the OR setting, not even to mention an outpatient office-based setting, the absence of anesthesia saves a significant amount of time and money. So other benefits, we mentioned the low complication rate, and we can talk about that a little more. The infection rate is essentially the same. There's a lower cost for a complete episode of care. There's no antibiotics needed for most cases, which can also decrease costs. You obviously don't have the anesthesia. You don't have the downsides of a general anesthetic, nausea, vomiting, urinary retention. Many of our patients are on anticoagulations, which you do not have to stop prior to a lot of these surgeries. We mentioned diabetics who don't have to be NPO and have an effect on their blood sugar. You don't have to visit your cardiologist or your pulmonologist before surgery, which saves on preoperative costs. This goes both ways. Some people are afraid of anesthesia. Some people say, put me out and I never want to see anything. So, those that are afraid of anesthesia, this is a great option. Talk a little bit about sterility as far as safety goes. Dr. Lalonde has looked at this as well as far as field sterility versus full sterility as an attempt to bring these surgeries out of the main operating room and into the clinic-based setting. Through thousands of carpal tunnel releases, the infection rate with field sterility, and I'll show an example of this, was the same as OR sterility. So field sterility is really just a couple of sterile towels, a couple of sterile drapes, and sterile gloves. You can see he's not, he's still wearing his watch, he's still wearing his tie, he has no surgical cap on. There's an arm board and a stretcher with 2 sterile towels. Versus an operating room setting where you have full draping, full gowning, and a full sterile table behind you. And both from a cost and an environmental standpoint, you can kind of see the difference between the two. In the person's right hand, that's a standard OR trash bin after a surgery, versus in his left hand, that's a wide awake surgery. So not only from an environmental burden, but just a cost burden. Obviously, the bigger bag costs the system more money. What procedures can be done? Almost anything, but mostly the common minor procedures that can be done quickly, such as carpal tunnel release, trigger fingers, lump and bump excisions, and minor Dupuytren surgery. And this is we've been experimenting with this in our office, and this was our tray for a carpal tunnel. So who is not a candidate for this? It's really anyone who doesn't want to. It's a discussion between the surgeon and the patient based on the patient's anxiety about surgery. I always ask people, are they prone to fainting if they see blood? And if I get a bad vibe about a patient, then we're not gonna go like that. And then, so in summary, wide awake surgery is safe. It's efficient. It's convenient for patients in most cases. It can decrease costs and increase value for the system. That's it.